Welcome to the new section on hyperthyroidism. In this particular section, we'll be discussing on the basic workup of how you're going to deal about a case of hyperthyroidism and a thyrotoxicosis. At the same time, we'll be discussing on one of the rare presentations called thyroid storm, and in between, we'll be discussing on the clinical features of hyperthyroidism as well. But before going into the depth of all these things, let us first understand what is the difference between the thyrotoxicosis and the hyperthyroidism. Even though both look a little similar, and even if you use thyrotoxin and hyperthyroidism interchangeably, there is no harm. It's not a big sin, but still you have to understand the importance of what is that small difference that exists between a thyrotoxicosis and hyperthyroidism. So to understand that, let me put two circles. The first circle, the bigger one, this is going to represent a larger spread of patients, and these patients I can call as thyrotoxicosis, right? So what do you mean by thyrotoxicosis? Thyrotoxicosis means these patients are going to have excessive thyroid hormones, maybe elevated T4 with an elevated T3, which is a common picture, or they might have elevated T3 alone, called as isolated T3 toxicosis. That's fine. So this larger group of patients who are going to have elevated thyroid hormones due to any reason will be termed as thyrotoxicosis. But let me put a smaller circle inside and probably shade it with red. And I can call this smaller state of patients inside this thyrotoxic group are going to be representing hyperthyroidism. So what do you mean by this? So hyperthyroidism means they are a subgroup of thyrotoxicosis, which means these patients also going to have elevated thyroid hormones in the body without a doubt. But this elevated thyroid hormones is going to come from thyroid gland's overproduction. So which means the thyroid gland is going to overproduce this thyroid hormones. That is the key point. Which means there are a group of patients who are living outside this circle, which I'm shading in blue here. These patients are going to have thyrotoxicosis, that is elevated T4, T3 or both. But these patients are having these elevated thyroid hormones not due to overproduction of thyroid hormones from the thyroid gland. Clear? Not due to overproduction of thyroid hormones from the thyroid gland. So that's the basic idea of classifying into two groups: patients who are thyrotoxic with hyperthyroidism and patients who are thyrotoxic but without hyperthyroidism. So now you can understand the word hyperthyroidism means the thyroid is hyper. They're secreting excessive, they're producing excessive hormones by themselves and releasing them in return. So how to differentiate? Is there any biochemical test? Yes, absolutely. Like whenever the patient is really hyperthyroid and thyrotoxic, the gland is overproducing the hormones. So which means for producing these hormones, they need that excessive iodine, so they're going to gobble up a lot of iodine. So obviously their radioactive iodine uptake will be very high. So if the patient is not overproducing the thyroid hormones from the thyroid gland, which means the gland is going to be silent and they will have a suppressed radioactive iodine uptake as well. Clear? So let us go back and see what do you mean by this radioactive iodine uptake. Radioactive iodine uptake, we are recapping the basic now. So radioactive iodine uptake, you're going to use I-123 as the principal isotope for testing this, and the half-life of which is approximately 13 hours. Or alternatively, you can use technetium-based tracers also. Very commonly we use technetium 99m pertechnate, which is going to have a half-life of 6 hours. In the sense, like any technetium-based tracer will be having a half-life of 6 hours only. We have already discussed in detail about the advantages and the disadvantages. So we're not going to discuss once again. You go back to the diagnostic section and you can see it yourself. At the same time, the normal radioactive iodine uptake at 4 hours is going to be somewhere around 5 to 15%, and at 24 hours, it's going to be double of that. It's going to be somewhere around 10 to 30%. So this is a normal radioactive iodine uptake. Anything more than 15% at 4 hours and more than 30% at 24 hours, we call it as a high radioactive iodine uptake. And anything less than 5% at 4 hours and less than 10% at 24 hours, we call it as a suppressed or low radioactive iodine uptake. So So these are the basics, right? So let us move on and discuss what could be the potential causes and how you could evaluate possibly the case of a thyrotoxicosis. So now assume that you're clinically suspecting thyrotoxicosis. When you're clinically suspecting a thyrotoxicosis, the patient is having clinical features of thyrotoxicosis, what are you going to do? The next step is obviously you're going to order for a thyroid function test. The reports may come in one of these two fashions. Either they could have a high T4, high T3 and a suppressed TSH, or a normal T4, high T3 and a suppressed TSH. So in both these groups, you are having elevated thyroid hormones with a suppressed TSH. Even though this particular entity where you have a normal T4 with an elevated T3 and a suppressed TSH, we call it as a isolated T3 toxicosis, which is a very good possibility in a patient with a Graves' disease. I'll discuss about that in some time, where sometimes in Graves' disease patients, they can have a preferential secretion of T3 alone sometimes. So let us discuss that. Or you could have a different picture, like you have a elevated thyroid hormones, but with a normal or a increased TSH rather than a suppressed TSH. This picture of increased or normal TSH with the elevated thyroid hormones usually goes towards a secondary or a central thyrotoxicosis. In general, we can call it as a central hyperthyroidism also. The causes are going to be very few, limited. In general, this is a very rare entity. You don't get this quite often. And the usual causes, if you want to know, it will be a TSH secreting pituitary tumor, otherwise referred to as a TSH-oma or a thyrotroph adenoma. Plus, please recall the fact that the TSH producing pituitary adenoma or a thyrotroph adenoma is going to be the rarest forms of pituitary adenoma. We know that the most common form of pituitary adenoma is a lactotroph adenoma secreting prolactin. But this TSH secreting pituitary adenoma is the rarest form, less than 1% incidence. You can go back and see the pituitary section once again. Or it could be some rare entities like pituitary level thyroid hormone resistance, which is often referred to as a Refetov syndrome, thyroid hormone resistance, which we have discussed in detail in the thyroid physiology itself. Now, what about this very common picture where you see this elevated T4, T3 and a suppressed TSH, or a normal T4, elevated T3 and a suppressed TSH? These patients will be deemed as a primary thyrotoxicosis. So you can call it as a primary hyperthyroidism as well, but there is a subtle difference. Even though if you call interchangeably thyrotoxicosis and hyperthyroidism, nobody is going to question you. But as a beginner, it's better to understand the basics well. So that's why you have to know the difference between a hyperthyroidism and a thyrotoxicosis. So I'm going to call it as a primary thyrotoxicosis whenever you have a suppressed TSH with elevated thyroid hormones. So now my duty is to find out whether really it's coming from the thyroid gland or it's not due to overproduction from the thyroid gland. So for that, I'm going to use radioactive iodine uptake as my test of choice. So my radioactive iodine uptake can be increased or my radioactive iodine uptake can be suppressed. I told you the values already, so you must be knowing by now. So when I'm having elevated radioactive iodine uptake, definitely I'm sure in the thyroid gland, I'm sure the patient is having thyrotoxicosis with hyperthyroidism. When I'm having a suppressed radioactive iodine uptake, I'm very sure that I'm dealing with a case of thyrotoxicosis but without hyperthyroidism. Both has a variety of causes. So when I'm dealing with a thyrotoxicosis with hyperthyroidism, elevated radioactive iodine uptake, more than 15% at 4 hours or more than 30% at 24 hours. So these patients can be further grouped based on pattern of radioactive iodine uptake. So if the pattern is homogeneous and diffuse, or if the pattern is heterogeneous and patchy, what are you going to see? If it's homogeneous and diffuse increase in uptake, the entire gland is lit up. So obviously, there is only one classic diagnosis possible, that is Graves' disease. But also note the fact that in Graves' disease, your thyrotropin receptor antibodies will be positive, which are very, very highly specific for Graves' disease. Even though they're not very sensitive, but still, these traps, if they are positive, they are highly specific for Graves' disease. If traps are positive, it is Graves, unless proved otherwise. That's it. It's a very highly specific thyrotropin receptor antibodies or TSH receptor antibodies called as traps. If it's a heterogeneous patch increased uptake, so again I'm going to classify into whether it's a focal patch increase or a multifocal patch increased uptake. If it's a focal patch increase, it usually goes towards a solitary toxic adenoma. We all know how a solitary toxic adenoma develops. Usually it comes from a pre-existing follicular adenoma where the TSH receptor in that adenoma goes for gain of function mutation. So because of that, they start disrespecting the TSH and they start producing thyroid hormones even in the absence of TSH. So this is called as gain of function mutation of TSH receptor. If it's a multifocal patch increased uptake, usually it goes towards a toxic multinodular goiter, where the mechanism is almost the same, but here there will be multiple nodules within the patient's thyroid gland, which will be going for autonomicity, and they'll start producing excessive thyroid hormones even without TSH. Clear? So this toxic MNG usually develops in iodine deficient areas with the mechanism which I told you already in the hypothyroidism section. So these patients generally tend to be younger, or they can be even happening in iodine sufficient areas where the patient tend to be relatively older, age more than 50. But the mechanism is the same, gain of function mutation of the TSH receptor happening in multiple nodules within the thyroid gland. So it is also worth noting the fact that even though I classified these patients under high radioactive iodine uptake, it's not a surety that this patient should have high radioactive iodine uptake, especially these patients who are having heterogeneous patchy uptake, because we are going to measure the entire gland's radioactive iodine uptake activity, not only a particular area's radioactive iodine uptake activity. So let me tell you what I'm trying to tell. So if you have a thyroid gland, and let us assume you have a lot of autonomic nodules within the gland. So these nodules are definitely going to show excessive activity. So let us assume this is a toxic MNG patient and they're having a lot of autonomic nodules which is having increased radioactive iodine uptake. Right. But why these patients are having increased radioactive iodine uptake? Because these areas, these patients will have TSH receptor mutations, which means they are going to have a gain of function mutations of this TSH receptor, which means even in the absence of TSH, they will take up extra iodine and they will be producing excessive thyroid hormones. But these areas that are autonomous and they are producing excessive iodine uptake and they are producing excessive thyroid hormones are going to give feedback to the pituitary and they're obviously going to suppress the TSH. The pituitary is going to respond to this excessive thyroid hormones and they're going to suppress the TSH. And this suppressed TSH obviously will suppress the remaining areas because the remaining areas are not having this gain of function mutations of the TSH receptor and they're going to respect TSH and they might have a suppressed radioactive iodine uptake. Which means there are certain areas in the gland which are having high radioactive iodine uptake and coupled with areas in the gland which are having suppressed radioactive iodine uptake. Which means the overall gland's radioactive iodine uptake might be variable. In a patient with hyperthyroidism, usually it will be increased or it can be even normal or even it can be decreased as well. It's highly variable. Clear? But in exams at least, you generally go for this increased radioactive iodine uptake. And it's actually an advantage because since the hyperfunctioning nodules are very bright in the radioactive iodine uptake scans and the remaining background gland is actually silent, in fact, they take up lesser radioactive iodine uptake, which means these nodules which are hyperfunctioning are nicely seen in the radioactive iodine uptake scans. These are brightly enhanced and they stand out in the background of a cold gland, which is a very good thing. You can see these nodules very clearly. And obviously these nodules going for malignancy, especially a hyperfunctioning nodule going for malignancy is extremely rare. We saw that already. The risk is less than 1%. You know the reason for why you have a elevated radioactive iodine uptake in these patients despite your TSH is low. You know this TSH is low in these patients. Despite having a low TSH, your radioactive iodine uptake is high. Because I told you one point that TSH is the most important stimulating agent for the gland, thyroid gland, to take up the iodine. So despite having low TSH, why they have elevated radioactive iodine uptake? That's the question. Why they had taken more iodine? Because here the problem is in this heterogeneous patchy uptake related conditions, especially a solitary toxic adenoma and toxic MNG, the problem is autonomicity. The thyroid gland, especially the nodules in the thyroid gland, those particular areas have become autonomic and they do not respect the TSH even in the absence of TSH, because the mutations they harbor, they're going to produce excessive thyroid hormones, and they subsequently they take up more and more iodine for the same. So they're going to have elevated radioactive uptake in that area. But in Graves' disease, the condition is different, isn't it? In Graves' disease, it's not the problem of this TSH. It's the problem of antibodies. For example, if you have a TSH receptor and these patients will have a thyroid stimulating immunoglobulin, which means these antibodies are going to stimulate the TSH receptor like how TSH stimulates the gland. And because of that, the gland is going to take up more and more iodine and they're going to produce more and more thyroid hormones and they're going to secrete the same. So which means here the problem is the antibodies and not the TSH itself. So here obviously this T4, which is produced in excess, is going to give feedback to the pituitary and they're going to have a low TSH only. Despite having a low TSH, this gland will have elevated radioactive iodine uptake because of the antibody stimulating the TSH receptor like TSH. Clear? So what are the causes of patients who are having thyrotoxicosis but no hyperthyroidism, which means these patients will have a suppressed radioactive iodine uptake. So what could be the causes? If you don't have hyperthyroidism, which means the gland is not producing excessive thyroid hormones, which means that excessive thyroid hormones is coming from either destruction of the gland or probably due to some extrathyroidal source itself. So I can divide into thyroidal source versus an extrathyroidal source. Thyroidal source, usually it is due to gland destruction called as thyroiditis. In exam, whenever you have a thyrotoxicosis without hyperthyroidism or thyrotoxicosis with low radioactive iodine uptake, your answer must be thyroiditis. That is the dictum in the exam. Usually that is what it goes towards. So it is thyroiditis almost all the time. But there are some other causes also, which means the thyroxine that is circulating in excess amounts in the body is coming from some other source apart from the thyroid gland. So what is that source? This source can be either an endogenous source or it could be even an exogenous source. Endogenous source means it's a very rare cause, but it comes from a source apart from the thyroid gland within the body. So that must be a tumor called as a struma ovary. Clear? It's a struma ovary, right? Or if it's an exogenous source, usually it means you're taking thyroid hormones from outside, maybe intentionally or unintentionally, which can happen even iatrogenically, where you prescribe a thyroid hormone which might be of too much dose to the patient. So in the long run, they might develop thyrotoxicosis. That's called a thyrotoxicosis factitia or a thyrotoxicosis medicamentosa. So there are different terminologies are there, but no need to worry about that. You can generally put under a condition called thyrotoxicosis factitia. Obviously, now you can understand the fact that these two conditions, where thyroiditis and struma ovary, you have endogenous source of thyroid hormones, which means these patients will have elevated thyroglobulin levels. Obviously, in fact, in thyroiditis, these thyroglobulin levels make a lot of sense because in thyroiditis, the first molecule to increase, even before the T4, T3 increase is thyroglobulin only. That's a very important point. Thyroglobulin is the first marker to get increased in a patient with a thyroiditis. And obviously, thyroglobulin will be increased in a patient with struma ovary also, because this patient is also going to have an endogenous source of this thyroid hormones, so that they will not produce only thyroid hormones, they will be producing thyroid hormones from the background of thyroglobulin only. So thyroglobulin will be increased in these conditions. But this particular condition, thyrotoxicosis factitia, where you're going to take thyroid hormones from the outside, you will be taking thyroid hormones from the outside, which means you're not going to take thyroglobulin along with the thyroid hormones. Even if you take thyroglobulin along with the thyroid hormones, for example, if you take a porcine thyroid gland, or you take some intentional intake of thyroid gland from animals, so in that case also you will not have elevated thyroglobulin, because this thyroglobulin, when you take inside, it will be destroyed by the stomach acid and the enzymes in the GIT, because it's a protein. Only the thyroxine will be absorbed, so there will be no elevation of the thyroglobulin. In fact, they will have a suppressed thyroglobulin in this condition. This is a very important entity to know. At the same time, how to differentiate between this thyroiditis versus a struma ovary? It's very easy. Obviously, if you suspect a struma ovary, do a pelvic scan. Clear? And do a radioactive iodine uptake. They will show ectopic increase in the radioactive iodine uptake, which means some ectopic radioactive iodine uptake will be there, usually in the pelvis. When you see this, you can argue about struma ovary. Other than that, it's always and almost a thyroiditis only. There are some theoretical causes where you still might expect a high radioactive iodine uptake and you have a thyrotoxicosis, which means hypothyroidism picture. So this is not important for a clinical practice, but theoretically these are important. So what are the causes? The number one is HCG producing tumors. So for example, a hydatidiform mole or a choriocarcinoma. So why these HCG producing tumors? You know that there are a lot of similarities between a beta HCG and a TSH. So let us assume this is a beta HCG and this is a TSH. We all know that their alpha subunits are almost the same, which means they are relatively similar with each other. And a lot of similarities with FSH and LH is also there. So, but in this condition, let us assume only the beta HCG and the TSH similarity. So whenever the beta HCG is produced in too much excess, so they can mimic a TSH and they can act on the TSH receptor in the thyroid gland. So which means this is a beta HCG that is acting on the TSH receptor and they are stimulating the thyroid gland to take up this excessive iodine and they produce this excessive thyroid hormones. And this excessive thyroid hormones, by feedback, they can actually inhibit the pituitary and they can suppress the TSH release. So they will mimic a primary thyrotoxic picture only, but they might be having a excessive radioactive iodine uptake as well, because it's the beta HCG that is stimulating the TSH receptor to take up the excess iodine. It's like a true hyperthyroidism picture only. So this is also one reason why in late first trimester, even in a normal pregnancy, your free T4 levels tends to increase a little bit and TSH level tends to drop a little bit. That is because of the explosion of the beta HCG, and which reaches a peak in the late first trimester, called as a gestational hyperthyroidism, which is an absolutely benign condition. So if you do a radioactive iodine uptake, obviously in these patients with HCG producing tumors, it will be high only. It's one of the causes of high radioactive iodine uptake in the thyroid gland, obviously without a doubt. But if you have a strong suspicion, you can do a pelvic scan and you can go by other diagnostic means, because you have a lot of clinical suspicion of choriocarcinoma as well, depending on what clinical profile you see. And there are some other conditions that can produce high radioactive iodine uptake and thyrotoxicosis. For example, a patient who's on amiodarone, very important cause. All right. Similarly, a patient who's having a low radioactive iodine uptake, if you want to know the cause, I can tell amiodarone here as well. So which means amiodarone is one drug which can produce high radioactive iodine uptake and thyrotoxicosis, and low radioactive iodine uptake and thyrotoxicosis, which means amiodarone can produce thyrotoxicosis with hyperthyroidism. Amiodarone can produce thyrotoxicosis without hyperthyroidism as well. Why? Because amiodarone contains a lot of iodine. At the same time, amiodarone can produce thyroiditis as well. So we have different types of amiodarone-induced thyrotoxicosis, which we'll be discussing later in the thyroiditis section. Don't worry about that. But amiodarone-induced thyrotoxicosis can be due to Jod-Basedow effect, where they take up more and more iodine, so that because of that, you might have excessive radioactive iodine uptake. Or amiodarone-induced thyrotoxicosis may be due to thyroiditis induced by amiodarone, where you'll have a low radioactive iodine uptake only. So it's a variable RAU, depending on what is the underlying pathophysiology. Let us discuss later on. And second, probably it might be due to iodine excess. So where this excess iodine by Ulchaikov effect can block the gland. Clear? So even in iodine excess states, because of Wilczek effect, you will have a low radioactive iodine uptake only. But iodine excess, remember, if you have a diseased thyroid gland, it may result in Jod-Basedow effect and it might even have an increased radioactive iodine uptake. But again, iodine excess is a different debate. In general, in exam, this is what you have to answer. Iodine excess will produce a low radioactive iodine uptake only in general, unless until they specifically mention on Jod-Basedow effect where you might have a increased radioactive iodine uptake. Clear? So these are some of the causes that you have to know. But there are some general things that you have to know when you are working up between these two causes. So what are the general things? Whenever you have this high radioactive iodine uptake, the first one to note is the classic cause I'm talking about. What are the classic causes? Graves, solitary toxic adenoma, and toxic MNG. These are classic causes. In these conditions, usually they will produce relatively increased T3 compared to that of the T4, which means in the blood, your T4 is much higher than T3, which means if you take a T4 and T3 ratio, it will be generally more than 20. We know the reason why. So, a lot of reasons are there. First, T4 is more stable in the blood. Half-life is more compared to that of the T3. At the same time, your thyroid gland itself produces more T4 compared to that of T3. So, a lot of reasons are there why your T4-T3 ratio is more than 20, which means T4 must be much higher by at least 20 times, 15 to 20 times more than T3 itself. But in these conditions, where you have a high radioactive iodine uptake, when you have a true hyperthyroid state, especially classic conditions like Graves' disease and toxic multinodular goiter, you might have a relatively excess T3, which means in these conditions, the T4 and T3 ratio might be less than 20, which means they preferentially produce more T3 compared to that of T4, relatively at least. And coupled with that fact, there are a lot of Graves' disease patients where you might have isolated T3 toxicity where they only produce T3 without T4 from the thyroid gland. That's also possible. But let us not confuse more. So point number two, these patients can generally be treated overall. I'm talking about overall, generally be treated with antithyroid drugs, absolutely indicated, like thionamides. You can treat them, no problem. And radioactive iodine ablation, yes, for toxic MNG and Graves' disease, again radioactive iodine ablation is one of the excellent treatments. And you can treat with surgeries as well, like thyroidectomy, lobectomy. So you can treat them with surgeries. In general, for toxic MNG and Graves' disease, we prefer a near total or a total thyroidectomy. Clear? So these treatments are indicated in these patients. Classic conditions like toxic MNG and Graves' disease, because they have high radioactive iodine uptake, which means it's a true hyperthyroidism, so that you can block the gland by giving antithyroid drugs, which means you can block the production of the thyroid hormones by the gland, or you can even ablate the gland and remove the gland by surgery, all of which are going to have a good improvement in the thyrotoxic features. But a patient who's having no hyperthyroidism, but they are thyrotoxic, which means the gland is silent, evidenced by low radioactive iodine uptake. Here there is no point in chopping off the gland by doing a surgery or giving a radioactive iodine ablation. Even though antithyroid drugs are also not indicated in this condition, but you can use in rare conditions like struma ovary, where you can block the ovarian production of thyroid hormones. But in general, antithyroid drugs for a thyroiditis, absolutely no, because the gland is silent. You have thyrotoxicos only because of the release of the stored hormones because of gland destruction. So you're not going to block the gland anymore, because there's no point in blocking gland because the gland is already silent. So no antithyroid drugs in thyroiditis. Struma ovary, yes, to an extent, but generally in a patient with a low radioactive iodine uptake, which goes towards the thyroiditis, you don't use antithyroid drugs. You only give a symptomatic subacute treatment, probably with the beta blocker during the thyrotoxic phase. And in thyroiditis, the thyrotoxic phase is going to be absolutely temporary and for a short period of time, like 2 to 8 weeks, not more than that at all. So there's no role for antithyroid drugs in thyroiditis. Struma ovary, to an extent, yes. But this thyroiditis, absolute no. And surely you're not going to use radioactive iodine ablation, and surely you're not going to use surgery in these patients. Absolutely no. Because the thyroid gland is innocent here. That's the problem. So you're not going to chop off the thyroid gland at all for any reason, or not going to ablate the thyroid gland. So these are some common things that you have to know. At the same time, the T3-T4 ratio or T4-T3 ratio, if you take, it will be more than 20 in a patient who's having a thyrotoxicosis without hyperthyroidism, which means they will have a proportional increase in both T3 and T4. Even though T3 and T4 are increased, there will be a very proportionate increase. So what happens in Graves' disease, let us assume this is T4 and this is T3 normal. This is a normal range. Let us assume T4 is always higher than T3. So in Graves' disease and toxic MNG, T4 increases, T3 also increases, but disproportionately. The gap will be less and the ratio will be less than 20. But what happens in patients with thyroid toxicosis without hyperthyroidism? This is T4 and T3 normal range. T4, T3 both increases, but proportionately so that the gap is maintained and the ratio is more than 20 still. So this is the idea. So these are some of the points that you have to note, the similar points between this group and that group. So with this, I think we have covered in detail about the evaluation of your hyperthyroid patients and thyrotoxic patients, and let us move on to clinical features of thyrotoxicosis. What are going to be the clinical features of thyrotoxicosis? So the classic presentation of thyrotoxicosis due to excess thyroid hormones, number 1 is restlessness, hyperactivity, and irritability. And this restlessness and hyperactivity is supposed to be the most common clinical feature of a hyperthyroidism. Or maybe I'm going to use thyrotoxicosis and hyperthyroidism interchangeably from now on. So don't get confused. So because almost both are the same. So from this point of view, from clinical point of view. Second is insomnia. Yes. This is quite opposite to what you see in hypothyroidism, isn't it? In hypothyroidism, you saw lethargy, hyperactivity, somnolence, excessive sleep. But here you are seeing insomnia, restlessness, and hyperactivity. So again, I want to tell you the fact that majority of the clinical features, not all, if at all, but majority of the clinical features in thyrotoxicosis will be due to hyperadrenergic symptoms or increased sympathetic activity. Why? Because we have studied in the physiology itself, and we have reiterated in the hypothyroidism section also that thyroid hormones, one of the basic function is to augment the sympathetic activity within the cell. By activating a lot of downstream pathways in the receptor level, effects of thyroid hormone is to increase the effects of the sympathetic system within the cell. So hypothyroidism will be like low sympathetic activity or hypoadrenergic state, and hyperthyroidism will be like hyperadrenergic state in the body. So they're going to mimic a hyperadrenergic or a hypersympathetic state like picture in the body. So insomnia, number 2. Number 3, you're going to result in tremors. Obviously, you know tremors are due to excessive beta-adrenergic activity. And number 4, you can get weight loss. This weight loss is very peculiar because this weight loss is going to happen with increased appetite. Usually, weight loss will go with decreased appetite, loss of weight go hand in hand, but very few conditions will produce weight loss with increased appetite. Like for example, at diabetes, you have polyphagia. They tend to eat more and more, but they tend to have a weight loss, especially you have insulinopenia. And people who are having hyperthyroidism, they tend to eat more because their basal energy consumption and basal energy expenditure is very high because they increase BMR, basal metabolic rate. So they tend to eat more, but they still go for weight loss. So these are very peculiar conditions where they have weight loss with increased appetite. And number 5, these patients might have a moist and a warm skin. That is because of excessive sweating. Again, due to hyperadrenergic state, more sweating, moist and warm skin. The opposite is what you saw in your hypothyroidism, where you saw weight gain despite poor appetite. And the patients had loss of sweating, which means the skin will be dry and they have xerosis. We have seen that already in hypothyroidism. And many of these patients tend to have tachycardia. And this is a very important thing because tachycardia is due to adrenergic effect on the heart. At the same time, direct thyroxine effect on the heart will produce tachycardia and increase workload and oxygen consumption by the myocardial cells. This tachycardia is supposed to be the most common sign in a patient with thyrotoxicosis, excessive thyroid hormones. And this tachycardia in the long run, due to enhanced automaticity on the myocardial cell, they can even go for atrial fibrillation, which by far is the most common arrhythmia to happen in a patient with hyperthyroidism and thyrotoxicosis. But remember, if you consider sinus tachycardia as an arrhythmia, that will be the most common arrhythmia. But I generally don't consider sinus tachycardia as an arrhythmia in thyroidoxicose. So AF naturally becomes the most common arrhythmia in thyrotoxic patient. This tachycardia and atrial fibrillation, if you don't treat it in the long run, if the tachycardia continues to happen for a long time, chronically, they can go for a type of cardiomyopathy called as a tachycardiomyopathy. Possible because of excessive workload on the heart due to continuous overbeating, which might result in tiring heart, and they may go for cardiomyopathy as well. And one of the important thyroid hormones' direct effect is lowering the systemic vascular resistance, lowering the SVR, systemic vascular resistance. It's a direct effect of thyroid hormone. Whenever you lower the systemic vascular resistance, you are going to reduce the diastolic pressure. Clear? So that is because of peripheral pooling, isn't it? The blood will go into the peripheries and get locked more, and because there is low resistance in the peripheries, so that you have a lesser central blood. So your diastolic BP obviously will reduce. So to counteract that, your cardiac output will increase in hyperthyroidism. So why your cardiac output should increase? Cardiac output is a function of, heart rate and stroke volume. Naturally, the heart rate in hyperthyroid patients will be high because of two effects: direct thyroxine-mediated effect on the heart and hyperadrenergic state that is happening in the body that will increase the heart rate for sure. And this stroke volume increase is actually due to this low systemic vascular resistance. Because the central blood, the amount of blood in the central circulation is less, the heart tends to struggle a lot and contract more vigorously to push more blood, so that they will increase the cardiac output to maintain the central volume, that losing central volume. So because of low systemic vascular resistance. So the cardiac output in general will be a bit high. So because with every beat the cardiac output is high, their systolic blood pressure tends to increase. That is why I told you hypothyroidism, by increasing the systemic vascular resistance, they are going to produce diastolic hypertension. Whereas hyperthyroidism, by increasing the cardiac output, they produce systolic hypertension. The pulse pressure is the difference between systolic BP and diastolic BP. So the pulse pressure will increase, resulting in a bounding pulse. So SBP, DBP, and the gap is what we refer to as a pulse pressure. Systolic BP increases, diastolic BP decreases. You'll have a wide pulse pressure, bounding pulse. Clear? So this is something bad, because in the long run, if you have this high cardiac output continuously for a long time, and this might result in a peculiar type of cardiac failure, because of excessive workload on the heart continuously for a long time will result in a type of cardiac failure called high output cardiac failure. In a patient who's having a very severe thyrotoxic clinical condition like thyroid storm, your fall in the systemic vascular resistance may be too high, so that your rising cardiac output may not even counteract that fall in the systemic vascular resistance, so that there will be a gross mismatch between cardiac output and the systemic vascular resistance, where systemic vascular resistance fall will be too much compared to the rise in the cardiac output, so that the patient might even go for a hypotension, and a true cardiac failure might ensue. So that's something like a thyroid storm you're going to encounter, so I'm not going to discuss right now. So number 8, you might have some nail changes like plumber's nails. What do you mean by plumber nails? These patients tend to have onycholysis. We know what is onycholysis. Onycholysis is separation of the nail from the nail bed. So you can see a visible gap between the nail and the nail bed. So that's what we call onycholysis. If it happens in thyrotoxicose, we call it as a plumber's nail. Number 9, you're going to get certain changes in the GIT also, gastrointestinal tract, where you will result in hyperdefecation or pseudo-diarrhea. Why I'm calling this as pseudo-diarrhea and not a true diarrhea? So remember, whenever you want to call a true diarrhea, the absolute quantity of the stool must be increased. For example, to tell a true diarrhea, the quantity of the stool must be more than 200 grams per day. That's an absolute increase in the stool volume and the stool quantity. Suppose I'm passing only 150 grams per day. This is the amount of stool I'm passing per day, but I'm passing this in 10 installments. 10 times I'm passing, each time only 15 grams per installment. I'm passing in 10 installments. You pass only 150 gram per day. The patient will tell it's a diarrhea because they're passing 10 times. Each installment is of 15 grams. But for me, it's not a diarrhea because the net amount is still within the normal range. So this is what we refer to as a pseudo-diarrhea or hyperdefecation. So what do you mean by that? That is nothing but increased stool frequency rather than actual increase in the volume of the stools. This is not a true diarrhea. So one of the important cause of pseudo-diarrhea in the world is IBS, irritable bowel syndrome, where the patient tends to complain to you as a diarrhea, but what they generally do is they pass only frequent stools rather than increase in the absolute amount of the stool. Any increase in the absolute amount of the stool more than 200 grams per day is not an IBS. It rules out IBS, to be honest. And it cannot be a pseudo-diarrhea. It's a true diarrhea. True diarrhea usually does not happen in hypothyroidism because it's due to irritation of the bowel causing more and more frequency rather than increase in absolute amount of the stool quantity. So we'll stop with it and move on to the next one. They can have exaggerated deep tendon reflexes, hyperreflexia. In hypothyroidism, you saw the exact opposite, constipation and hyporeflexia. They might even develop osteoporosis. That is due to effect on the bone, which I'll discuss in some time. And they may even develop a stare and a lid lag. Often this stare and a lid lag, which is characteristically called as a thyroid stare, is confused with Graves' ophthalmopathy. Remember, Graves' ophthalmopathy is a completely different entity. It is unrelated to thyrotoxicosis. We'll discuss in some time. But thyrotoxicosis itself can cause this characteristic thyroid stare and lid lag. Why? Because of the increased sympathetic nervous system activity on the eyelids. So what do you mean by that? So in the eyelid, you have one important muscle called as a Mullus muscle, which is actually the very important muscle that prevents you from prevents your eyelids from getting closed when you are not voluntarily opening your eyelids. For example, when I'm seeing the camera now, I'm not voluntarily voluntarily keeping my eyelids open. For that, LPS is important, levator palpebrae superioris. But my subconscious level, my autonomic nervous system is keeping my eyelids open because of the Mullus muscle, because it's stimulated by the sympathetic nervous system. So what really happens in hypothyroidism and thyrotoxicosis is the fact that you'll have excessive adrenergic state, which means you have excessive sympathetic nervous system activity like picture. So your Mullus muscle will be hyperactive, which means your eyelids will open widely, more than what is required. So this more opening of the eyelids is the reason for what you get this characteristic thyroid stare. And this is also the reason why this lids will go for retraction. This is called a lid retraction, and it's very difficult to close down because this sympathetic system is overacting and it's preventing the eyelids from closing fast. So that is the reason why you get a lid lag. So what do you mean by a lid lag? So when I'm asked to look down, look at my eyes carefully. When somebody asks me to look down, you can see my eyeballs are moving. At the same time, my eyelids are also moving at the same time. Right? My eyelids are also moving at the same time. So if my eyeballs move down when I'm asked to look down, but my eyelids lag behind, it's not moving as fast as my eyeballs. So this is what we refer to as a lid lag. So this typical wide palpebral fissure because of the wide opening of the eyelids, at the same time coupled with this lid lag, gives us two important signs called as a Dalrymple sign and a Van Graaff sign. So let me tell you what you mean by Dalrymple sign and a Van Graaff sign. You can see in this particular video where this patient, when he tries to look down, you can see very clearly the eyelids lag a lot behind the eyeballs. Clear? It comes later than the eyeballs. So this is what we refer to as a Van Graaff sign. And I'll show the Dalrymple sign also in the same image. So I'll fix in the neutral point. So now you can look at my eyes. My eyes, you cannot see the upper part of the sclera above the cornea. And some part of the cornea is covered by the upper eyelid in neutral gaze. But see this patient, you can very clearly see the upper part of the sclera. So usually the upper part of the cornea and the sclera above the cornea should not be visible and it should be closed by the upper eyelid. But in this patient, the sclera is visible, isn't it, above the cornea. So this is what we refer to as a Dalrymple sign. This is one of the most common signs to happen in patients with thyrotoxicosis and probably with hyperthyroidism and Graves' disease. So Dalrymple sign just tells you that it's a white palpebral fissure that happens in thyrotoxic patient. And we also demonstrated von Graff's sign. Von Graff's sign is nothing but you're getting a lagging eyelid, especially the upper eyelid, on down gaze. When the patient tries to look down, you're going to have a lid lag. And you have multitudes of signs. In fact, trust me, you have multitudes of signs that is often confused with Graves' ophthalmopathy. Remember, these signs, what I'm going to tell, are signs of thyrotoxicosis and not Graves' ophthalmopathy. Graves' ophthalmopathy is a very, very different entity. So what are the signs of thyrotoxic eye disease? Let us see. So this is only for theoretical importance, and if you know already, you can skip this as well, not a big deal. So let me tell you some of the signs like Griffith sign. So what do you mean by Griffith sign? Griffith sign is nothing but the same lid lag can happen with up gaze. So von Graff is nothing but classical lid lag with down gaze, we call von Graff, but lid lag with up gaze, we're going to call it as Griffith sign. Then you have Koch's sign. Koch's sign is the entire globe lag behind. It's a globe lag. The entire eye will lag on the up gaze. So this is called Koch's sign. The entire eyeball will lag, so it will move slowly. So that's a Koch's sign. Then you have a Geoffroy sign. Geoffroy sign is absent wrinkling on the forehead. Absent wrinkling on the forehead, especially on up gaze. So when you look up, usually you develop wrinkles on the forehead. If it's absent, it's called as Geoffroy sign, sign of thyrotoxicosis. Then you have a Stellwag sign. And you have two signs. One is called a Stellwag and a Pochin sign. Both are related to blinking. Both are related to blinking. So what do you mean by Stellwag sign? Stellwag sign is reduced blinking rate. So whereas Pochin sign is nothing but reduced blinking amplitude. The amplitude of blinking will be reduced. Then you have other signs like Jelinek sign, otherwise referred to as the Racine sign. Jelinek sign is nothing but hyperpigmentation of the eyelids. It's a eyelid hyperpigmentation. That's what we call a Jelinek sign or Racine sign. Then you have a Rosenbach sign, where you see tremors in the eyelids, especially when the eyelids are closed, you see this tremors in a closed eyelid. So that's called a Rosenbach sign. Then you have a Gifford sign, where there will be difficulty in averting the eyelids. Averting the eyelids. That's called a Gifford sign. So obviously there will be eyelid retraction here. Because the eyelid retraction and severe contraction of the Muller's muscle, they'll be like hyper contracted, and it's very, very difficult to avert these eyelids. So that's what we call it as a Gifford sign. And you have a Boston sign, where you'll have an irregular jerky movement, very irregular and jerky movement of eyelids on down gaze. So this is called as Boston sign. And finally, you have the last sign that's called a Grove sign, where you will feel the resistance to attempted pulling the retracted upper eyelid. So if your retracted upper eyelid is there, you are attempting to pull down this retracted eyelid down, and you'll feel a lot of resistance in that. So that's because of already Muller's muscle is contracted and the eyelids are retracted up. It's very difficult to pull them down. So this is what we refer to as a Grove sign. So these are different signs that are described in thyrotoxicosis. Almost every single sign I have mentioned here is due to excessive sympathetic nervous system activity on the Muller's muscle. That's it. And it's due to hyperadrenergic state happening in the body, which can happen in any thyrotoxic patient in a long-standing thyrotoxicosis. So that is why these signs are not specific for Graves' ophthalmopathy. These signs are specific for thyrotoxic, because Graves' ophthalmopathy happens due to a different pathophysiology, that is inflammation and autoimmunity and formation of antibodies. That is the reason why you get Graves' ophthalmopathy. But this is completely different. This is due to hyperactivity of the sympathetic nervous system on the Muller's muscle, causing a lot of these signs. So don't confuse these signs with Graves' ophthalmopathy. These are the signs of thyrotoxicosis. That's why this I'm going to call this thyrotoxic eye signs rather than Graves' ophthalmopathy. So this is not equivalent to Graves' ophthalmopathy. Remember, proptosis, exophthalmos, chemosis, eyelid edema, optic nerve compression. These are specific terms. Restricted extraocular muscle movements. These are terms that are specific for Graves' ophthalmopathy. But remember, whatever the signs I've told you, these thyrotoxic eye signs are not equivalent to Graves' ophthalmopathy. Please be very clear about that. Now, finally, last but not the least, the 13th one I'm going to discuss is about the Means-Lerman scratch. MEANS means Lerman scratch. What do you mean by this Means-Lerman scratch? It's nothing but a scratching sound that you're going to hear over the mediastinum when you're going to auscultate this patient with overt thyrotoxicosis. That is because in long-standing thyrotoxicosis, the pericardium and the heart will keep rubbing on each other, so the pericardial surface may become a little rough because of hypercontractile nature of the heart. This irritated pericardium will go for thickening a little bit. So whenever the heart touches this irritated pericardium again and again during hyperdynamic contraction, they might go for a scratching sound. They can create a scratching kind of a sound called as a Means-Lerman scratch. And what are the metabolic effects? These are the clinical effects, but what are the metabolic effects of thyrotoxicosis and hyperthyroidism? Obviously, they are going to produce excessive glucose. We know why, because it's like a hyperadrenergic state, isn't it? One of the features of hyperadrenergic state is to produce excessive glucose, because catecholamines are known to be catabolic to the body. So that is the reason why you get weight loss also. Catecholamines are known to be catabolic and they break down the proteins, and those amino acids will be shunted towards gluconeogenesis. That is why hyperthyroidism and thyrotoxicosis is one of the important endocrine causes of hyperglycemia and diabetes mellitus. Clear? So metabolic, hyperglycemia. Then you might result in hypercalcemia. So why hypercalcemia? That is due to osteoclast stimulation. And this osteoclast stimulation is happening through this beta-adrenergic pathway. So once they are stimulated, they resorb the bone more and more, and they are going to produce hypercalcemia. And these patients tend to have hypercalciuria also. Urinary calcium also may be increased. Probably partly in relation to hypercalcemia, because whenever you have a hypercalcemia, you must have a hypercalciuria due to calcium sensing receptor mechanism in the kidney, which we'll discuss later on in the endocrinology of the bone. But right now, this increased urinary calcium may be due to another reason also. That one reason will be this alpha adrenergic pathway that is happening in the kidney. In the kidney, this alpha adrenergic pathway, once it's activated, they can also produce this increased urinary calcium called as hypercalciuria. So these are the metabolic effects. So hypercalcemia, hypercalciuria, and hyperglycemia. So one of the important endocrine cause of diabetes is hyperthyroidism and thyrotoxicosis. You have to know about that. So we have covered in depth about all the clinical features and the metabolic effects of hyperthyroidism and thyrotoxicosis. We have to know the differential diagnosis for these clinical features now, because there are some 2-3 questions in the exam based on the differential diagnosis for this thyrotoxicosis. Number 1 is based on the neuropsychiatric effects of the thyroxine. Neuropsychiatric effects of thyroxine is completely, like a big spectrum. So we're not going to discuss in detail about that, because a patient who's having a thyroid storm may present with a coma also. That's severe elevation of the thyroid hormones may even result in a coma. A patient who's thyrotoxic for a long run even can develop a dementia. It's been proven in many experimental models, and it's been proven in some patient studies as well. So we're not going to such details. But at a basic level, they're going to produce restlessness, hyperactivity, insomnia, right? So obviously, It's one of the very important DDs for anxiety neurosis. So usually before diagnosing a functional disorder like anxiety neurosis, it's always prudent to rule out a hyperthyroid state by doing a thyroid function test. Fine. Number 2. Second DD is based on the weight loss, because weight loss with increased appetite. Most important DD is diabetes mellitus. But other uncommon DDs is tuberculosis and malignancy, where you do tend to have weight loss in TB and malignancy, but you have a loss of appetite as well. But the most important DD here is diabetes mellitus, where for all diabetes mellitus patients, I do a thyroid function test because of multiple reasons. Reason number 1, thyrotoxicosis itself may result in diabetes mellitus. And thyrotoxicosis itself may have hypertension, which can coexist with diabetes mellitus. Clear? At the same time, when a patient is having diabetes, having a hypothyroidism, I'm telling why I do a TFT. Hypothyroidism, both may act synchronously and may increase the cardiovascular risk. So that is the reason for every diabetic patient, I'm going to do a thyroid function test. And both diabetes and hyperthyroidism, thyrotoxicosis may produce weight loss as well with increased appetite, with polyphagia also. So you have to be careful. So diabetes thyroid function test, usually in my practice, it became mandatory. So because of various reasons, I believe it should be done. Number 3. So you can give differential diagnosis for cardiac symptoms. So where they may develop high output cardiac failure in the long run, where CCF becomes a very important differential diagnosis. Then for the hyperadrenergic symptoms, drug toxicity and drug poisoning, especially with sympathomimetic drugs like cocaine and amphetamines, even anticholinergic drugs like belladonna and atropine toxicity. This also becomes a very important differential diagnosis for the hyperadrenergic symptoms that thyrotoxicosis produces. So these are some of the important DDs that you know for clinical thyrotoxicosis and associated symptoms. In general, anxiety neurosis becomes the most important clinical DD as far as exams is concerned. Now we'll be moving on to the last section on thyroid storm. Thyroid storm. So thyroid storm is an extreme form of thyrotoxicosis, right? So where the patient will be having overt end organ failure. So it's extreme form of thyrotoxicosis. Usually what is the reason for thyroid storm? But general thyroid storm has now become an obsolete complication, very, very rare, because we know why this happens and we have already avoided this. And it's a very rare complication right now. So, but it's prudent to know, at least for the exam sake. So what is the cause of thyroid storm? So usually in thyroid storm, these patients will be overtly hyperthyroid, which means the problem is the gland overproducing. For example, Graves' disease, a very common cause of thyroid storm. So whenever you take this patient for a surgery, like a thyroidectomy, so make sure that this patient has a good pre-op preparation and make this patient's euthyroid by giving a good amount of antithyroid drugs or probably iodine, so and make the patient euthyroid for sure. Then only you take the patient for surgery. Suppose if you don't make the patient euthyroid, still if the patient is in hyperthyroid state and you take the patient for surgery, there is a very, very high risk of developing a thyroid storm. Very common with Graves' disease. So which means the most common cause of thyroid storm is going to be inadequate pre-op preparation in a patient who is hyperthyroid and you're taking them for surgery like thyroidectomy. So this is the most common cause. Even though spontaneous thyroid storm has been described in literature in patients who are having overt sepsis, but they're having background hyperthyroid state or any other stressful events like even a minor surgery, it's been described, but it's almost always due to inadequate preparation in a patient who's taken for thyroid surgery before doing in a patient who's already hyperthyroid. So this is the most common reason for thyroid storm. So since the surgeons are now well aware of this complication, so they make sure they don't take for surgery unless and until the patient achieves this euthyroid state. That's the reason why this thyroid storm has become a very, very rare complication. But it's a potential complication that you have to know. So how will you diagnose? Remember, thyroid storm is a diagnosis of both clinical as well as laboratory background. Laboratory is very, very important because often they forget the laboratory and they see clinically and they diagnose the patient as thyroid storm. Remember, clinically, if you make the diagnosis of thyroid storm, 99, not 100% of the times you will be wrong because it's a very rare entity. Don't make diagnosis clinically. So always do the laboratory profile where you'll have extreme elevations of the thyroid hormones with definitely disproportionate elevation of T3 because many of these patients are true hyperthyroid patients. So they'll be having disproportionate elevations of T3 and the T4 T3 ratio will be less than 20 usually. And at the same time, they'll be having undetectable TSH. Even by 4th generation assay, if you do the TSH, they'll be less than 0.001. This is a must to diagnose a thyroid storm. I mean, at least practically. Clinical feature wise, patients will be having fever. It's like extreme thyrotoxicose and extreme sympathetic surge. Patient will be having extreme tachycardia, and many of these patients may even have a atrial fibrillation ongoing, and patients will have severe GIT symptoms like severe hyperdefecation, and patients will surely have evidence of end organ dysfunction. And often people forget that this end organ dysfunction is one of the prerequisites for diagnosing a thyroid storm. So what are the end organ dysfunctions they might encounter? Like probably neurological dysfunction, like delirium, and even a coma has been described in a lot of patients, and cardiac failure. So remember, this cardiac failure, especially this high output cardiac failure, is the most common cause of death in these patients. Remember the fact that despite treatment, this thyroid storm has almost 20 to 50% mortality, which means this is a very bad disease to get. So better to avoid. So 20 to 50% mortality despite treatment, in spite of treatment. So don't take risk. Always prepare the patient well before you take for surgery, especially the patient is already hyperthyroid like Graves' disease. BP in a patient with thyroid storm is actually variable. They may range from hypertension to hypotension because it depends on the match between systemic vascular resistance and cardiac output. If the systemic vascular resistance falls too much so that the increased cardiac output cannot match, you will end up with hypotension. Why? Because this increased cardiac output will struggle too much. Over time, they will fail because of the excessive workload, and they even go for hypotension. So BP is actually quite variable in a patient with thyroid storm. So now anyway, you have made a diagnosis clinically as well as laboratory wise. Now how you are going to treat this patient with a thyroid storm? You have diagnosed it now. Treatment wise, the first treatment always is going to prevent the mortality, which means you are going to first prevent the death of the patient. What was the most common cause of death? Heart failure, cardiac failure. So you're going to give cardiac protection with beta blockers. Beta blockers reduce the energy consumption, reduce the heart rate, reduce the tachycardia, and prevent the arrhythmias to develop. Even if the patient is in AF, they reduce the rate. They're very good, isn't it? So beta blockers are going to be the first line management to prevent the death and give cardiac protection to the patient. What we prefer generally is propranolol. But there are a lot of modern studies which tell that you can prefer cardioselective drugs like esmolol or metoprolol. Beta blockers give one more added advantage, that it can block the peripheral conversion of T4 to T3, which is quite important in a patient with this thyroid storm, especially these patients have a background of hyperthyroidism, isn't it? These are background hyperthyroid, which means they have a disproportionate elevation of T3 than T4. So this beta blockers are little good because they also affect the peripheral conversion of T4 to T3. But remember, this propranolol has more inhibitory effect on the peripheral conversion compared to this cardioselective beta blockers. But yes, I mean, whatever you want, you can follow. In my center, I generally prefer metoprolol for cardiac protection. Excellent drugs. But remember, be careful to avoid these beta blockers in patients with having a frank pulmonary edema. Obviously, in a pulmonary edema patient, negative inotropic agents are not advised. So you have to avoid them. Apart from that, you have standard beta blocker related contraindications like COPD, bronchial asthma, reactive airways disease, prolonged PR interval more than 0.24 seconds, hypotension and shock. So you know that we'll be discussing the cardiology section. But apart from that, beta blockers are excellent drugs in a thyroid storm patient. These are the first drugs to be given, life-saving drugs. And the second treatment will be to block the ongoing thyroid hormone production. So which means, again, I told you a lot of times that thyroid storm happens in a patient who's overtly hypothyroid, which means there will be ongoing thyroid hormone production. So you have to block them. So how you're going to block them? By giving two drugs. One is thionomides and second is iodine itself. So what happens in the thyroid gland? We know they take up the iodine, they produce this thyroid hormones, and they're going to release this thyroid hormones, and this T4 in the periphery, it will be converted to T3 by D1 deadenase. So first you have to block the production. So by blocking the production, first you give a drug called thionamide, which blocks the production of T4 and T3. So thionamide of choice is propylthiouracil. Why? Because it can be given IV, number one. At the same time, this thionamides, especially propylthiouracil, is the only thionamide that can block the peripheral conversion of T4 to T3 as well, which is a very important problem in patients with thyroid storm. Very high T3 levels because they are overtly hyperthyroid, disproportionate T3 increase. P2 is very helpful here. That's the reason. Second, you can give iodine itself, which itself acts as an antithyroid drug, which can act as both blocking agent as well as a inhibitor of release. So iodine can act at two levels, and iodine can further act on the peripheral conversion as well by inhibiting the peripheral conversion of T4 to T3. So iodine is very good drug. So by principle, you can see that iodine acts at multiple places, and it's one of the very potent antithyroid drugs. But still, if you take your textbooks, that are clearly mentioned that you give propylthiouracil first. IV, almost 1 to 4 grams of loading dose of propylthiouracil is what we give. This will be followed after 1 hour, and we are going to give iodine in the form of either potassium iodide or Lugol's iodine. Why is that so? Why, even though iodine is very potent, you are trying to give after 1 hour, after giving propylthiouracil? So again, that goes back to the basics. I told you thyroid storm patients, majority of them will be already hyperthyroid. Clear? Which means there is a pre-existing thyroid disease. In a patient with pre-existing thyroid disease, I've clearly mentioned that there will be defective autoregulation, where giving iodine sometimes might result in excessive production of the thyroid hormones rather than blockade of the gland, called as Jod-Basedow effect. This usually happens in patients with pre-existing thyroid disease, where patients with thyroid storm also will have pre-existing thyroid disease. There is a theoretical and more than theoretical, a practical possibility that this iodine, whatever you give, might be utilized for production of more and more thyroid hormones, and you might result in more and more worsening thyroid toxicosis and thyroid storm. So that's why we don't give iodine first. First, make sure you give propylthiouracil or any other thionamide. I mean, in this condition, it's always propylthiouracil, and you block the production first. Make sure you block the production. Then you give iodine, which will block the release as well as peripheral conversion. So that is the reason why we give PTU first, iodine next. And there are some adjunctive therapies which you can use in a patient with a thyroid storm. What are the adjunctive therapies? Number one is dexamethasone, adjunctive therapy, or any other steroid for that matters, because this is usually very effective in Graves' disease patients, because Graves' disease is usually due to inflammation and antibody formation. So dexamethasone may be effective in this regard, and at the same time, you know, this dexamethasone and steroids can reduce the peripheral conversion of T4, T3 as well. So multiple regards, it might be useful. And number two, you can use IVIG and plasma exchange, plasmapheresis. IVIG is going to remove the antibodies that are seen in Graves' disease, so it might be useful in selected cases. And plasma exchange again can remove the antibodies seen in Graves' disease. At the same time, there is evidence that plasma exchange can remove the thyroid hormones as well. So these are the adjunctive therapies that you can use. So it's always about the first treatment, that is life-saving cardiac production, beta blockers. Second treatment, block the ongoing production by giving propylthiouracil followed by iodine. Then finally, adjunctive therapies. We always follow in our institution dexamethasone every time, but IVIG and PEGs under specific certain conditions. Clear? So this is how you're going to treat a thyroid storm. So these are the detailed explanation of what is thyroid storm and how you're going to treat a thyroid storm. With this, I think we have finished the thyroid toxicosis and hyperthyroidism section, and this is more than enough. And let us move on to the next section on Graves' disease, which is going to be an autoimmune thyroid disease section.